Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clunit, serving as a located session assistant to ensure a seamless experience. Clunit proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clunit serves as a director partner for this event, jointly hosted by Karnataka chapter of IACTA, Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anesthesiologists, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Healthcare Foundation USA. And the focus of today's session is left ventricle assessment. Now I will play the ICA welcome video to welcome you all. Just allow me a moment. Now, I would like to welcome Dr. Muralidhar Kanchi, sir, for the further proceedings. Over to you, sir. Thank you.
Thank you so much, Rimpa, for this introduction. I'm extremely delighted to welcome you for this Sunday breakfast session webinar dealing with echocardiography. As already mentioned, this is being conducted under the auspices of Indian College of Anesthesiologists, Indian Association of Cardiothoracic Surgeons, Global Heart Care Foundation, Global Intensive Care Symposium, and the International Society for Cardiac Ultrasound.
Hello, Sanjay, I'm not able to hear any volume from that side.
So I would like to request Dr. Raghu to share his screen and then start the...
this one only.
I would like to request Raghu to share his screen and start the presentation. Today's topic is right ventricular assessment by echocardiography. Right ventricular assessment by echocardiography, not left ventricle as announced in the flyer. It is right ventricular assessment by echocardiography. Dr. Raghu, please carry on. And Dr. Raghu is a prominent cardiac anesthesiologist with extensive experience with echocardiography, and I think he's the right person to deal with this subject. Thank you so much. Over to Dr. Raghu. Raghu, please unmute yourself.
Okay, sir. Now, sir.
Please share your screen.
Yeah. Okay, sir.
Rimpa, can you please share the screen?
So he needs to share it.
I've shared it, ma'am.
So have you minimized your slides?
Ma'am. Yes, ma'am.
So have you minimized your slides before sharing?
Yes, ma'am.
Okay, so you need to come to the Zoom, then you need to click share icon, then only you'll be able to share, sir.
Okay, ma'am. Now?
Yes, your screen has started sharing, sir. Minimize this. Yeah. Now make it in a full screen.
Okay,
Yeah.
ma'am.
Now click on the hide icon, sir, which is reflecting in the screen.
Hide.
Yeah,
Yeah.
yeah, yeah.
Okay.
Yes, sir. You may proceed, sir.
Morning, everybody. Today I'm going to talk on right ventricular assessment. I'll talk on RV anatomy, assessment of the RV size, assessment of the RV function, and assessment of RA function, and a case study on the PTE. Coming to the right ventricle anatomy, right ventricle is a thin, free wall and crescentic shaped structure when compared to the conical LV, and RV is asymmetrical and it is wrapped around the left ventricle. Because of the high degree compliance to accommodate large volume, normally ejection from the right ventricle occurs at low resistance to the pulmonary circuit. Coming to the anatomy includes the inlet, which starts from the tricuspid valve, the chordae tendineae, and the papillary muscles. The trabeculated RV starts from there up to infundibulum, and the outflow tract starts from the infundibulum up to the pulmonary valve. Coming to the cut section of the RV consists of three bands, that is the moderator band, the parietal band, and the septal or medial papillary band. The parietal band and the supraventricular the parietal band and the infundibulum joins together to form the supraventricular crest. The septal or the medial papillary muscles descends downwards inferiorly, joins the moderator band to the anterior papillary muscle. If you look at the cut section of the RV, when compared to the RV, compared to the LV, the RV is more trabeculated. It has got more papillary muscles, and the septal leaflet is more shifted towards the apex of the RV. Um, Coming to the right ventricular contraction, RV contraction happens with the contraction along the long axis from base to apex, the inward movement of the free RV wall, the circumferential contraction of the RV outflow tract, and the bulging of septum into the RV chamber. This is the longitudinal movements which happens from the base to the apex. This is the radial movement, and this is the anterior posterior motion. When combined this, we get the all we get all the three motions. If you look at the contraction of the RV, we see like a peristaltic movement on the free wall of the RV. This is because the sinus and the apex, they contract 20 to 50 seconds earlier when compared to the infundibulum. That is why we see the peristaltic movement on the RV free wall. Now, coming to the ventricular interdependence, the main anatomical determinants of ventricular interdependence is intraventricular septum. Both both RV and LV are attached towards the intraventricular septum, and these two ventricles are enclosed by the pericardium. The cardiac output of the RV and LV is same, but when in case of pulmonary hypertension, the RV enlarges, pushes the septum towards the LV, and it forms a D-shaped LV. So the septum is pushed towards the LV, and it causes a D-shaped LV both during systole or during diastole. This is the ventricular independence, which can be expressed in eccentric ratio, the ratio between the anterior posterior diameter to medial to lateral diameter. Normally, it should be less than 1. But in case of pressure overload, the septum is pushed towards LV during systole, where it causes the eccentric indexity more than 1 during systole. Whereas in diastole, if it pushes the septum towards the LV and causing a D shape, during diastole, it is volume overload. So these are the normal views which is helpful in assessing the RV. This is a four chamber where we can see the free RV wall and the apex and the tricuspid valve. This is the RV inflow outflow valve. We can see the RV OTO. We can measure the RV free wall thickness. This is but transgastric basal view, where we can see all the septal leaflets RV OTO, where we can take the gradient. This is the RV inflow view, where we go over to the transgastric at zero chamber, where we see RV inflow outflow view. where we can measure the MPI index. This is a RV focused view. When you look at the RV, if you want to take any measurement, you should always look from base to apex. You should see the RV free wall moving continuously during the whole cardiac cycle with the apex intact, and we should get the view, and then you have to measure the linear measurements or the fractional area change. If you want to measure, you should see, get a focused view before measuring it. So coming to the RV free wall thickness, which can be measured in M mode in mid-esophageal RV inflow outflow view. Normally, the thickness is 1 to 5 mm measured at the end diastole, and you should always exclude the trabecular and the papillae muscles, and always it is difficult in case of thickened pericardium. Normal thickness is up to 5 mm, more than 5 mm, it is called hypertrophy. And coming to the measurement of the linear dimensions during diastole, when the tricuspid valve, during systole, when the tricuspid leaflets are closed, just below the tricuspid leaflets in the RE focus view, we can measure the RV D1 diameter, and just at the mid part of the RV, we can measure the RV diameter too, and from the center of the RV D1 to the apex, we can measure RV D3, and this diameter, if it is more than 41 mm, more than 35 mm, or more than 83, then we tell RV is dilated. And these are the normal values which are up to the indexed to body surface area. These are the normal chambers. It's all in the guidelines. Coming to the assessment of the RV assessment should never be done visually. This is a paper from the jail. We tell when you assess visually, the assessment is very less when compared to the quantitative. Always there is a wide inter-observable variability is there. Quantification always improves the accuracy, reliability, especially in distinct normal to abnormal. So RV visual assessment should not be done. Coming to the assessment of the RV function, the regional function, that is the TAPSE or the tissue Doppler S prime can be done, or the global function assessment can be done with RV fractional area change, MPI index, 2D strain, and 3D RV ejection fraction, and isovolumic acceleration. Coming to the TAPSE can be measured in the deep transgastric four-chamber view, where we can put a Doppler beam across the lateral tricuspid annulus, and with the M mode, we can see the exertion. It usually measures the longitudinal RV shortening. Normally, it should be more than 70 in mm, and it represents the longitudinal muscle function. Only thing, the angle between that lateral tricuspid annulus and the free wall surface, it should be minimum. The more the angle, the TAPSE doesn't give a correct values. But this is all load dependent factor, and it is a load dependent, angle dependent factor. In AF, it causes a drop in the TAPSE, and TAPSE is a prognostic indicator where we can see if the TAPSE is more than 14, the survival of the patient is more when compared to the TAPSE which is less than 14. And always there is a strong correlation between the TAPSE and the fractional area change. If you see, the TAPSE is between 1.5 to 2, and you can see the FAC is more than 50 to 60. There is always a strong correlation between these two. And if you want to do the tissue Doppler, you place it pulse wave Doppler at the lateral annulus and do TDI. You get the tissue Doppler. The peak S wave after the QRS complex, the velocity after the S wave complex is the S prime. If it is less than 9.5 centimeters second, it shows there is an RV dysfunction, and this reflects longitudinal muscle fibers. This is angle dependent, load independent factor, and it is a prognostic indicator when compared to the outcome of the patient. And coming to the fractional area change, it is the area change between the end systole to diastole. You can measure the end diastolic area minus the end systolic area divided by the end diastolic area. The fractional area change, if it is less than 35%, then it is considered as an abnormal. Coming to the RPI index, if you place a pulse wave Doppler at the RV inflow outflow view, you can get this tricuspid inflow and the RV ejection, and this can be measured by the tricuspid closure to opening time to the ejection time by the ejection time. That is the end of E wave, the onset of ejection is isovolumic contraction time, or the end of ejection time and the onset of E wave is isovolumic relaxation time divided by the ejection time gives the MPI index. With pulse wave Doppler, it is normally less than 0.3, and with tissue Doppler, it is less than 0.54. Anything higher, it shows there is an abnormal RV. Coming to the RV strain, the degree of myocardial deformation compared to original length, which is expressed in percentage, is the strain. In RV strain, usually it should be normally between minus 25 to minus 29, and abnormal when it is less than minus 20. And coming to the assessment of 3D RVEF, normally there is a lot of upgradation in the software, so it can be easily measured RVEF, and usually it correlates to the MRI. And normal RVEF is more than 45. Both the trabecular and the moderator band should be included in the cavity. And with 3D echo, there is no geometric assumption when compared to the 2D. This is RV volume assessment with comparison with the MRI, CT, and 3D echo, and it shows the CT always overestimated and the 3D underestimated RV volumes when compared to the MRI scans. And this is a isovolumic relaxation time which is load independent and tissue Doppler derived parameter. Normal value is more than 1.1 meters per second square for the RV. If you look at this is the calculated by dividing the peak pre-myocardial ejection. You should take the peak velocity and divide it by the time from the onset to reach the peak time, gives you the isometric acceleration. This is load independent factor which can be assessed for accurately assessed for RV dysfunction cases. Coming to the RV to PA coupling, normally the RV ejects blood to the low resistant pulmonary circuit. Whenever there is a pulmonary hypertension, the RV hypertrophies and try to compensate the cardiac output by hypertrophy so that the RV to PA coupling happens. When there is an increase in the afterload, when the RV cannot able to contract, then RV to PA uncoupling happens, and this by echo can be calculated by TAPSE to pulmonary artery pressure, which is normally around 1.2. When it is less than 0.64, then the mortality is more. Coming to the RV diastolic pressure, if you place a pulse wave Doppler at the tricuspid valve at modified Baker value, we can get the E and A wave. We tell whether there is an impaired diastolic function when the E by A ratio is less than 0.8 and pseudo normal filling between 0.8 to more than 2, and restrictive filling it is more than 2.1. Coming to right atrial strain, this is the deformation of the RA with the assessing the functional capacity of the right atrium. There are three functions of the right atrium, that is the reservoir, the conduit, or the pump strain, or the booster strain. The RV strain in reservoir strain measures the stretching of the right atrium during ventricular systole when it fills the blood, whereas the RA conduit strain reflects the passive emptying of the atrium into the right ventricle during early diastole, whereas the booster strain or the pump strain represents the active contraction of the atrium during late diastole to fill in the ventricle. This is a curve where we can see the reservoir, conduit, and the booster. This helps in assessing the prognosis of the patients in RV failure. When we put the patient on treatment, the reservoir phase usually comes down when compared to the anatomical thing, because the anatomical anatomical values usually takes long time to come, but the reservoir phase usually it decreases in size. We can see if you measure right atrial strain, we can see the decrease in the reservoir strain. And coming to the RA assessment should be done in ventricular end diastole. That is, you tell right atrial enlargement when the RA area is more than 18 centimeters square, and the RA dimension, the length of the RA from superior up to the closure of the tricuspid value annulus should be more than 53 and the diameter from the IAS to the lateral wall of the RA, if it is more than 44 then we tell RA is dilated. See, you should always try to assess the right atrial pressure by echo. That you can see by assessing the IVC diameter in pre-op, and this can be done at the end expiration proximal to the hepatic veins. If the IVC diameter is less than 2.1 centimeters and it is more than 50% collapsing, then the RA pressure is 3 of Hg. If it is less than 2.1 centimeter and less than 50% collapsing, then you tell the RA pressure is 8 of Hg. If it is more than 2.1 centimeters and more than 50% collapsing, then again it is 8 of Hg. If it is more than 2.1 centimeters and less than 50% collapsing, then you tell RA pressure is say that is 15 of Hg. This is a case of PTE where we can see the RV is bulging the septum towards the LV because of the increase in PA pressure. You can see both during systole and diastole, the septum is moving towards the LV. And when you look at this image, you can see the thrombus in the RA appendage. You can see a mass in the RV. And in these cases, we are not able to float the PA catheter. By echo, we can assess the pulmonary artery pressures. See, pulmonary artery systolic pressure can be measured by measuring the tricuspid TR jet gradient. That is by simplified Bernoulli's equation, 4 into TR maximum velocity square plus right atrial pressure. And coming to the pulmonary artery diastolic pressure, you'll take the Doppler at the pulmonary valve. You see that if there is a PR registration, the pulmonary artery diastolic pressure is measured into 4 into PR end diastolic velocity square plus RAP, right atrial pressure. And the mean pulmonary artery pressure can be measured by the acceleration time or the PR, peak early velocity, plus RAP. You can measure the mean pulmonary artery pressure. And this is the upper esophageal aortic short axis view. From the DTA, if you withdraw the probe, you get the upper esophageal aortic long axis. From there, you increase the angulation to 90-degree, you get the upper esophageal short axis. And if you place the Doppler, your pulse wave at the RVOT, you get a trace. The time of onset from the baseline to reaching the peak is pulmonary acceleration time. Normally, it is 100 to 110 milliseconds. In case of pulmonary hypertension, or when the mean pulmonary artery pressure is more than 60, the pulmonary acceleration time will be less than 60 seconds. When there is a PAH, normally you see a blunting of this pulmonary wave, where you see the initial peak is due to the increase in the arterial impedance, and the second peak is due to the peripheral obstruction. Or if you make this thing as inverted, it is also called as W sign. And pulmonary vascular resistance by pulmonary catheter can be calculated with the mean pulmonary artery pressure minus the wet pressure by the cardiac output. By echo, it can be calculated 10 into TR velocity divided by pulmonary valve VTA plus 0.16. And this is the LV and RV strain can be measured because there will be a RV dysfunction. LV dysfunction will be there because the septum is pushed towards the LV, so that there is a diastolic filling impairment will be there. Both these things can be done using echo in PTE cases. And this was a study done at NH, correlation of the pulmonary acceleration time with PA pressure undergoing in PTE patients. PAT was significantly negative correlated with mean pulmonary artery pressure irrespective of before or after CPB in patients undergoing PTE. But PAT was investigated to correlate positively with parameters of RV function like TAPC, or right ventricular FAC, and right ventricular function. So whenever the PAT values are lesser, that means the RV function was lesser, which was correlating with the TAPC, EF, and FAC. This is a study done at NH, that is the portal venous pulsatile fraction, which is a known marker of RV dysfunction in PTE patient. In bicaval view, when you get the IVC, advance the probe inwards and advance the probe, and then you will see with the below the IVC, you will see a hyperechoic round structure, which is the pulmonary vein. By increase angulation to 90 degree, you get the portal vein long axis. If you put if you put a Doppler, you will get a waveform where the pulsatile vein pulsatile fraction can be measured by the peak measurement to minimum measurement divided by the maximum. And the result of this study was independent relationship between RV dysfunction and portal vein pulsatility in patients undergoing in PTE, and pulsatile fraction was found significantly negative correlated with TAPC, FAC, and RV ejection fraction. Coming to the conclusion, RV shape and physiology is complex. The limited data available on dimensions because of the complex geometry, visual assessment of the RV is always inadequate. RV function is strongly associated with the clinical outcome. With pulmonary artery catheter and the echo, RV dysfunction can be managed efficiently. Thank you, sir.
Thank you. Thank you, Dr. Raghu, for that excellent talk on assessment of RV function using echocardiography. Very well done. You touched upon, initially you started with the abnormal or non-geometric anatomy of the right ventricle and the parts of right ventricle, that's inlet, body, and the outlet, and how the peristalsis like movement occurs when the RV contracts. And then you went on to the eccentricity of the LV because of the RV dysfunction. And then you touched upon various functions of the right ventricular assessment in terms of TAPSE, yes, prime velocity, the global longitudinal strain of the right ventricle strain pattern, the myocardial performance index. Then you also mentioned about RA strain and RVPA coupling. And thank you for that talk. And you also mentioned your own, our own work on the pulmonary acceleration time and correlation with the pulmonary artery pressure and the portal vein pulsatility. With that, I would like to open this for discussion. And I would like to go through the chat box. First question is, how do you differentiate chronic pressure overload on RV from acute overload? Does RV hypertrophy occur in chronic conditions? That's the question. Raghu, can you please address this question? How do you differentiate chronic pressure overload on the
Chronic,
from acute overload?
Okay, so, sir, in acute overload, there won't be initially hypertrophy of the RV, and
Right.
the septum usually doesn't bulge too much. It doesn't cause D-shaped LV when compared to the chronic hypertrophy. And one more thing, if you have a PA catheter, if you look at the RV trace, you can see the S pattern on your upslope, which is usually seen in chronic hypertrophy. But in acute, you won't see the upstroking on this one. And in acute cases, when you give volume, the systemic pressure improves. Whereas in chronic, you should never give more volume. You should actually remove the volume.
Yeah, yeah. Thank you for that response. Actually, right ventricle as compared to the left ventricle is acutely decompensated if there's acute increase in the afterload. So it doesn't tolerate, and right ventricle gets dilated immediately, and then right ventricle failure, and the forward output suffers straight away. So and whereas the left ventricle, to sudden increase in the afterload to some extent is compensated by the intrinsic homeostatic mechanism called unwrap effect, where there is increase in the contractility to be able to withstand the acute increase in the afterload. This is on the left side. But the right side, this mechanism does not um, occur to a large extent, and RV becomes dilated and bloated, and the patient promptly goes into acute hemodynamic collapse. Any other responses? Anybody wants to comment on this? We'll go to the next question, that is S prime by tissue Doppler, which view is used?
We can use the deep transgastric four chamber view where we can put the tissue Doppler at the lateral annulus and we'll get the S prime. I think that is the best thing. Only thing, the angle correction, you should have the minimal angle between your Doppler beam and the lateral annulus. It should be less, so you get the accurate view.
Absolutely. The angle must be taken into account. They should be absolutely parallel to the tissue motion to get precise values. And in TTE, we can use the apical four chamber view and go to the septal as well as the lateral S prime. Anybody wants to add anything to this? Any of the faculty members who are present do want to add to this? Next is which view MPI can be measured?
MPA can be measured in transgastric RV inflow outflow view. You place a Doppler, this one pulse wave Doppler at the tricuspid inflow. You get the tricuspid inflow and the outflow, pulmonary outflow. That is the best view to do it.
Okay. As correctly pointed out, when you talk about MPI, lesser the better. Higher it is worse. The function is impaired. Next question is how to do volume assessment by 3D. How to do volume assessment by 3D. Dr. Raghu, are you there?
Yes, sir, I'm there, but I'm in our machines. We don't have this one RV 3D assessment volume software, sir. I have no idea. Actually, I asked one of our pediatric cardiologists. They were telling it is easy if you go to the this one four chamber view, mark the points on the lateral annulus and the apex, and put a 3D this one. Usually it cuts a different plane and it aligns, they told, but I have not done it, sir.
You know that. Okay,
No.
okay.
Sir, I can probably address this.
Yeah. Please feel free.
Yes, sir. So I think Rachna probably asking for this 3D volume assessment by the echocardiography. So now, sir, we have for some time we have used this Philips machine, which has a auto RV 3D software. So basically, we need to take a 3D full volume data set, then going back to review, and once we open the 3D full volume data set, it will give you the options if you have the software, the 4D auto RV. Then once you click it, this machine will automatically generate a 4D model. But obviously, it's a semi-automated, so you can um, change the marking and borders if it needed be, and that gives a endostolic volume and systolic volume and 3D ejection fraction of the RV. And recently, we are using this Siemens machine, which has again 4D AI. They call it 4D AI software, which gives a
Mhm.
both, RV ejection fraction and RV strain. It also give RS strain at the same time. It's a beautiful software. So it's very easy. If the machines have these softwares, obviously machines have to have these softwares. Then it's very easy, sir. Not difficult.
Thank you. Thank you for that input. And
Thank you, sir.
anybody else wants to comment on this? Raghu, I just wanted you to put up that slide on RVPA coupling.
Mm.
Can you go back to RVPA coupling?
Yes, sir.
Please blow it up. Yeah, yeah. See this TAPSE by PASP normal value is 0.5 to 0.7.
Okay.
Just check this because
Okay, sir.
the recent recommendations from the American Society of Echocardiography, the RVPA coupling ratio, that is TAPSE to PASP, normal value is 0.5 to 0.7, which means TAPSE is 15 and PASP is 30. So it becomes 0.5.
Okay.
So just a comment, on the discussion and all for everyone. Recently, not recently, over last few years, a lot of emphasis has been given on the hemodynamic data collection from the echocardiography and PA catheter for the
Mhm.
RV, particularly as we're doing more LVAD cases. So the hemodynamic data is like to determine why the RV is failing, whether patient has a high PVR or not. And in case the patient has a high PVR, whether it's a fixed PVR, it's a fixed component, or it's a flexible component, dynamic component. For that, this PA elastance and PA compliance, those things not alone possible from the echocardiography, but obviously with the PA catheter and echocardiography together, and obviously the role of PAPI, pulmonary artery, and it's the PAPI and this RV PA coupling. All these things are so important nowadays because we can prognosticate essentially with all these parameters that how RV is going to do after the surgery or after a procedure.
Yes. Yes. Yeah, yeah, yeah. You're 100% right. In the lab, you can get the end systolic elastance of the RV and the arterial elastance by putting the pressure volume loops and decreasing the preload to the RV, and then constructing the graph and getting the end systolic elastance of the RV. But in clinical practice, it is difficult to do all these things. So we go by the available parameter, which is TAPSE and pulmonary systolic pressure. And it's easy to do, and it's reasonable substitution for the end systolic pressure volume relationship in the right ventricle. And I think it works out reasonably well. And we also have an index called PAPI index, which is the pulmonary arteries pulse pressure, pulmonary artery pulse pressure divided by RA pressure. This also is a reasonable indicator or prognostic indicator to determine whether right ventricle is going to fail at the end of LVAD implantation. So that is another point which can be added to the
Yes,
discussion.
sir. And so the TPG and DPG, this TPG,
Yes,
DPG, and PAPI, these three things are very important. You can do very easily in our
yes,
clinical setting. That gives us a lot of information.
yeah, yeah, yeah.
Muligar,
Yes, 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 yes.
I just read it that RVEF divided by pulmonary artery strain index also give good amount of coupling and between right heart and lung.
Sure, sure, sure. Actually, they have,
Strain.
yes, yes. To know the right ventricular function, you can use TAPS. TAPS is commonly used, but you can use a fractional area change, or as you said, ejection fraction also can be used. And in the denominator, you have to have an index of the pulmonary artery compliance cum resistance parameter.
Pulmonary
Wo-
strain, any software has come for that. I don't know.
no,
Pulmonary artery
I have
strain.
not seen it, but the basic principle is that you have to have a factor of the right ventricle on the top and a
Hmm.
factor of the pulmonary artery on the bottom and get the ratio. And for each set of these two relationships, the RVPA parameters, there is a specific number which you have to remember, below which it may be abnormal.
And coming
You're
about
right.
talking about this congestion due to RV failure, do you use Vexus or only pulmonary? Sorry, portal PAPI, pulmonary portal artery pulsatility index, or do you use renal as and hepatic vein also? That
Very
is
good question.
Vexus scoring.
Yes. Raghu, please respond to this.
No, sir, I have no this one. We usually we take care of the patients in the OT. I don't have experience in
Hmm.
using
It is
this one in
basically
assessing IV.
transthoracic, yes.
Yeah, no, no, sir. I have.
Because
Mm,
Yeah, yeah, yeah. Yeah, continue, sir, Dr. Sanjeevani. Please
and the
continue.
portal vein, basically these are done on transthoracic before surgery, of course. But if it is there's a very standard grading. If a IVC is more than 2, then only they do it.
Yes, yes.
And then hepatic vein, renal vein, and portal vein. These three.
Yeah, that is true. That is true.
And
What happens?
then that beautifully they come back to normal after treatment. That is the beauty in that. So you can demonstrate how beautifully it has come.
Yes, yes. I totally agree with you. What happened on the left side when you look at the left pulmonary venous blood flow? Same thing happens here. There is blunting of the S wave to start with, and then reversal of the S wave as the severity worsens. So this all can be demonstrated in the Vexus score. And what I wanted to point it out is that the IVC diameter is described or mentioned as 2 centimeters in the literature, but in Indian population we don't get 2 centimeters normally.
Mhm.
It's 15 to 16 centimeter millimeters. Sorry, not centimeter, millimeters. So this also has to be kept in mind. Maybe we should develop our own scoring or determination of RA pressure depending upon the IVC diameter and its collapsibility or distensibility, depending upon whether the patient is spontaneous breathing or on mechanical ventilation. What do you say, Dr. Sanjeevani, on this?
Yes, yes, absolutely.
IVC is
We
never two
can have
centimeters.
IVC of 1.5 still patient congested very enormously. So
Yeah,
because
yeah.
they are 30 kilos, BSA of 1. So
Right,
it is
right.
absolutely. So I do excess even if it is less than 2. It's a practice,
Yes, yes.
maybe, that you should do excess irrespective of IVC diameter.
Right, right.
Yes, actually, I mean, see, I also second her. I mean, what Sanjivani madam has told. The only problem is that Vexus is recommended for non-ventilated patients. I mean, the patients who are ventilated,
Pre-operative,
then
yes.
But the thing is that you can still see the trend. If there is any, the portal vein is very easy to see in TE. And if there is any pulsatility in the portal vein, particularly more than 30%, say more than 50% pulsatility of the portal vein, that means venous organs are definitely congested. And as Madam rightly pointed out, this RV function is not now bound to RV. It has gone beyond the RV to see how the organs are getting congested with a vexus core. And
Sure,
in this
sure.
regard, this diastolic dysfunction of the RV, that is also quite important because many of the cases, particularly say in repair top cases or congenital cases or any other cases with a big RV hypertrophy or the RV systolic function still be maintained. You can see still a normal TAPSE or normal FSC, but the RV diastolic function can be, quite significant. Grade 2 or grade 3 diastolic dysfunction can be there, which is quite difficult to treat until diagnosed.
And
Yes, yes. Actually, I would like to add one point before Sanjeevani. The not only up to the renal vasculature, that is renal artery, renal vein, but also now they are looking at the femoral venous pulsatility. It has
Yes.
gone up to that level. So
Mm.
it's a evolving science, and we have to see how all these parameters can be used to aid the patient management in a clinical setting. Sanjeevani, you were saying something?
yes, yes. The new thing, I mean, it's not a new thing now that TR gradient now no more will give you exact quantification of pulmonary hypertension. It gives only probability. Now they have come to that conclusion because sometimes there is torrential TR, but still RV is not that bad, like that.
Mm, yeah, yeah, I agree. I agree.
Uh,
Raghu, what's your comment on this?
Well, sir, when in with low pressure RV, the
Yes,
TR jet velocity will be less. At
correct.
that time, if you take the TR VTI for assessing the pulmonary artery systolic pressure, definitely it will be wrong only.
It will be underestimated. Yes, yes,
Underestimated. So you should
yes.
not do it. As Madam told, it is correct only. It is only useful in normal RV function to assess the PA pressure. I think the TR
Mm,
gradient.
mm, mm.
and about this annulus of tricuspid valve, should we give that value diameter of annulus to benefit surgeon to guide them whether to address it or not during surgery? Tricuspid valve annulus diameter.
Yeah, ma'am. Actually, we should take 2.1 times the index value. Now the index is 1.6. It is almost
Okay.
comes 33, 34 mm. If it is more than that, then we have to this repair the valve. We should try to repair the tricuspid valve. It is 2.1 times into BSA gives you
Hmm.
the tricuspid annulus size.
Right, right. Which prevents RV failure later
And
on, after
yeah,
10
yeah, ma'am.
years, 15
Correct,
years.
correct, ma'am.
Is it not correct to say that the indexed tricuspid annulus should, if it is more than 2.1 square centimeter, it should be addressed?
Yeah.
Yeah. Any other comments or questions? We have about
Sir, this is Dr. Jagdish from Goa Medical College.
yes, Jagdish, please.
Yes, sir. Sir, tricuspid annulus, as you said, it is correct, sir. Recently, we had one case of tricuspid valve prolapse in a 20-year-old child. If you calculate her end systolic tricuspid annulus, it is coming only 35. But if you index it to body surface area, it was around 24, 25 millimeter per meter square body surface area. So anything more than 21 has to be addressed, sir. Because if you only go by end systolic linear diameter, it will be less than 40, 42 actually. So index body surface area has to be more than 22 has to be addressed in case of tricuspid valve.
Thank you for your comment.
And
Thank you
other
so
thing,
much.
sir, other thing I wanted to add is
Yes,
for
yes.
RV systolic function, I think RBVT VTI value has to be taken into account whenever we are measuring RV acceleration time.
RVVTA, yes.
Yeah.
Yes.
So more than
RVVTA can be
18 is
measured.
considered normal, sir.
Sure, sure, sure. Thank you for that added point.
Yes.
Sir, can I comment?
Yes, yes, yes. Please, I have about 5 minutes to go.
Yeah,
Please do
Dr.
that.
Raghu, very nice presentation. Regarding RV strain, sir, I want to tell that RV strain is a very important predictor nowadays, because RV strain, in Philips machine, we have a software when we calculate RV free wall strain and longitudinal strain. So both will come, and RV free wall strain is more specific for RV dysfunction compared to RV longitudinal strain, because in longitudinal strain, it will take the septum also. So some contribution from interventricular septum also affects the RV function. But RV free wall stain is a very important predictor following cardiac surgery for to find out that post-op RV dysfunction will happen or not. So that's a very important point.
Yes, yes, I agree. I agree. Actually, I tell my residents that to remember the atrial strain, right atrium or left atrial strain, you just remember RCP. RCP is retrograde cerebral perfusion, but it's not what I want to mean here. It is R stands for reservoir, C for conduit, P for pump. So
Yes,
you
sir.
just remember this mnemonic RCP. You will be able to remember what are the three parts of the right atrial or left atrial strain.
Very true, sir. Yeah.
Yes, yes.
There is one question over there.
Right,
Avinash,
right. We'll read it
IVC
out.
diameter and assessment of RA pressure. How will
Yes,
you
yes,
correlate
yes.
in mechanical ventilation?
In mechanical ventilation, how will you relate the IVC diameter and determine the RA pressure? Can I, after Raghu, I'll answer this question. Raghu, tell me.
This one, IVC, you have to put this M mode on the IVC diameter, that is around zero point 0.5 to 2 centimeters below the opening of the IVC, and put a M mode. You get the measurement. You should see any variation is there, where any collapsibility is there or what. Depending upon the measurement, then we can say. But most of these measurements, whatever we are having at the guidelines, is in the patients who are on spontaneous ventilation. So when you have an IVC which is big, which is non-collapsing, and the hepatic veins, you see reversal of SVM, that usually the IVC diameter is usually enlarged. That shows the RA pressure is more than 15. That requires aggressive management, diuretic management for that patient. Actually, in a mechanically ventilated patient, it is difficult to correlate, but in spontaneous patient, it is always easy to measure the IVC, see the collapsibility index, and assess your RA pressure.
Right, right. Thank you, Raghu. I just want to add that when we talk about IVC diameter and how much it varies during respiration, we have the collapsibility index when spontaneously breathing, and the distensibility index when the patient is on mechanical ventilation, when patient is fully paralyzed and being ventilated. So distensibility index is the maximum minus minimum diameter of the IVC, usually done using the M mode divided by minimum diameter. So you take both the values, minimum and maximum. Maximum minus minimum divided by minimum is the distensibility. If it is more than 18%, it indicates volume responsiveness. And actually, one of my fellows under me is looking at the distensibility and correlation to the right atrial pressure, because most of our patients have central venous pressure, right atrial pressure, and the endoscopic area. And because most of these patients are being ventilated nowadays with 6 ml per kg of tidal volume, we cannot use the pressure pulse pressure variation as a parameter to indicate fluid responsiveness. For pulse pressure variability index, pulse pressure variation, you need to have a tidal volume of at least 8 ml per kg. So we are not able to include that, but these three parameters, my fellow is looking and just trying to see the correlation using statistical methods and coming to some conclusion. That's my response to this. And are there any
So,
more questions?
Raghu, Muralidhar, can I ask him?
Yeah.
Yes, Raghu, can you tell something about recent guidelines on RV function
Yes.
2025?
Yes. Yes, ma'am. Tell me.
No, recent guidelines on RV.
Ma'am, recently the American Society of Echocardiography on 2025, I think August, they have released the new guidelines. It is there, ma'am, in the
So they
website.
have graded, now they have graded the things which was never there. So they have graded mild, moderate, severe. And they have said that you must have one qualitative, one quantitative, and one diameter like that. They have.
Okay.
Yeah, don't go by single parameter. And another
Yeah.
important point which has to be mentioned, if you don't mind, one other important point which has to mention is that if the RV is more than 2/3 the size of the LV in longitudinal axis, or it is equal to LV, or it is greater than LV in size and forms the apex of the heart. These three are indicative of mild, moderate, and severe right ventricular distension and hypertrophy and failure.
Yes, size and
Yes.
shape is very important.
Yes.
Yes, sir. And yeah, at the same time, sir, you have to do a measurement also. Sometimes the LV is dilated,
Yes.
sometimes LV is dilated. And so comparing the RV to that LV, RV is also maybe dilated, but with LV so much dilated, so the dilated RV may be looking small. So measurement of the basal, mid, and
Yes.
longitudinal area.
It's a biventricular failure we are talking about.
And sir, regarding the discussion you are doing about this IVC, distensibility and collapsibility index, I think the PEEP on mechanical ventilation, that will the degree of PEEP we are giving, that
Yes.
actually influence
Sure.
this IVC a lot.
Mm.
So
Yes.
SVC probably a better parameter, but IVC is also we can do, as you rightly said, sir, distensibility index.
See, when you're measuring distensibility, we are not applying any PEEP. But as
Hmm.
you said, when you're applying PEEP, the intrathoracic pressure dynamics will be different in terms of transthoracic pressures and the lung compliance, how much is actually being transferred to the contents in the mediastinum and the structures within the chest wall. All this
Yes.
will contribute or modify the parameter which is being measured.
You have taken
And
a very nice study, sir. Your student is doing a very good study.
We
I
are
must
just
say.
trying to see.
Yeah, absolutely brilliant. Yeah.
But
yeah,
only thing is, I was sad that I cannot add the PPV because
Okay.
we are using tidal volume of 6 ml.
Hmm.
So maybe I should increase it to 8 ml and then add it up. So we'll get 4 parameters.
Yeah. We are thinking to do it on one lung ventilation, sir. In minimally invasive cardiac surgery, we are planning to
Yes.
do it on one lung. So we'll see how one lung further, affects the SVC and
Yes.
IVC and all.
Yes.
how do
Thank you
you
so
do
much.
SVC on TE?
Which
Arun,
one?
SVC diameter on TE, how do you do it?
You go to bicaval V1, simple bicaval view,
Oh,
and
yes.
you put
I
a
got
M
it.
mode.
Yeah.
M mode. And also you can probably also measure it in the proximal ascending aortic short axis view
Short
in
axis
it
view.
is
Yes.
at 0 degrees. There also you can measure the diameter. Thank you so much. And I think time to conclude.
One small thing for students actually.
Yes.
Difference between RVOT and LVOT, just our physiology and anatomy, and how it correlates to our clinical setting. Difference between RVOT and LVOT, just for the students, Raghu.
Okay.
Can you just elaborate on that? Difference between LVOT and RVOT, physiology as well as anatomically, and then how it is bothering us clinically.
I
Ma'am,
think Sanjeevani, you only tell because I need to
Okay.
close the
See, this
session.
is very simple actually, just for the students that LVOT is a fibrous structure, fixed. it doesn't contract.
Right.
But RVOT is a muscular structure and it does contribute to RVEF also, and it contracts. And the importance is in tough cases, many times after induction, infundibular spasm can create a big problem for us during induction. You have to really prevent that. Of course, they are on beta blockers. That is the main thing to prevent. But sometimes patient can become hypoxic just after induction.
Thank you. Thank you.
Infundibular spasm. That is just for the students actually.
Thank you. Thank you,
Sir, one last
Sanjay.
comment,
We
sir.
really appreciate.
Just 10 seconds for last comment. Actually, that's why, sir, most of the parameters which gives global RV function, because they don't take the RVOT in for that
Yes,
RV
yes.
global function. That's why 3D RV ejection fraction is the only parameter
Yes.
which considers everything RVOT.
Yes,
And
yes,
that's
yes,
why it's a
yes.
gold standard.
Yes, yes, yes. It is comparable to CT
Yeah.
MRI. Yes, yes. Thank you so much. And I would like to thank Raghu for that excellent talk. And I would also thank Sanjeevani, Arup, Jagdish, and others who have participated in discussion. There was a real good discussion. And we look forward to having you again next Sunday for a new topic. Please join us by about 8:45. And before we conclude, there is an announcement of the IATA TE program, which is being conducted at Narayana Hrudayalaya during the month of August. Please join us in this international event. Thank you so much and have a great Sunday. I would like to thank both Rimpa and Raju for the technical assistance. Thank you so much. Good luck.
Thank you, sir. Thank you, everyone. Thanks.
Sir? Sir, may I play the last video? So thank you so much, everyone, for joining this session. Planet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much, everyone.